Thank you very much. It's really a pleasure to be here. It's my second time to Nijmegen, and it's even more beautiful in the sun than it was in the rain a few years ago. But the talks have been fantastic, and it's been a really wonderful meeting. So my topic today is ventilator-induced lung injury. I actually changed the title slightly to New Insights rather than State of the Art, because in the 20 minutes I thought it might be useful to just go over some recent developments rather than trying to cover everything about ventilator-induced lung injury in a 20-minute talk. Conflict of interest has no relevance, I don't think, for this meeting, but I do consult for McKay Critical Care and a couple of other companies. So what I'm going to do over the next 19 and a half minutes is give you a very brief review of ventilator-induced lung injury and talk about some new things related to impact of villi on the lungs, and actually potentially impact beyond the lungs on the brain. And finally, I'm going to end off spending a few minutes on a recent article that was published on driving pressure, because I think that has relevance for how we take care of patients at the bedside, and then I'll conclude. So some of this is taken from a review article we wrote about a year and a half ago on ventilator-induced lung injury. And in that, you saw this picture yesterday, actually. You know, ventilator-induced lung injury can occur by ventilation at relatively low lung volumes when the lung is allowed to de-recruit and to recruit, so something called adlec trauma, and is due largely to lung inhomogeneity. So Jerry Mead back in the 70s had a wonderful paper showing that inhomogeneity is really what's important. And that's important in terms of clinically, because that's why people do recruitment maneuvers and try to recruit the lung and make it more homogeneous. Injury can also occur with ventilation at very high lung volumes. That can lead to barotrauma, gross air leaks, or over distension, something called volutrauma as well. And both of these can have structural consequences, as you can see here, with changes in the epithelium, development of hilum membranes, increased alveolar capillary permeability, which means that ventilator-induced lung injury in many ways simulates what happens with ARDS, where there's an increase in alveolar capillary permeability. There can be fibroproliferation, I'm going to talk about that, and also epithelial mesenchymal transformation. And I'm going to be talking about that in a few slides. And that's where epithelial cells actually transform into mesenchymal cells, which can potentially lead to fibrosis. So these are sort of, if you like, various methods, various approaches, various problems with mechanical ventilation and injurious ventilatory strategies. There can also be physiologic abnormalities caused by this injury, with, as we know, increased dead space, decreased compliance, which is largely related to less lung being ventilated than actual structural changes that lead to compliance changes, and of course hypoxemia and hypercapnia. Biological alterations, biotrauma, with increased mediators in the lung, and these mediators can cause various cells to be recruited to the lung, and all this milieu that occurs in the lung can therefore injure the lung even more. So that's the backdrop to the first thing I'm going to talk about for a few slides, and that's the fact that mechanical ventilation, there's evidence now, can not only cause gross barotrauma, cause biotrauma, but potentially can cause pulmonary fibrosis, lead to pulmonary fibrosis. So this is a study published a few years ago by Cabrera and Benitez and colleagues, and the idea was to examine the impact of mechanical ventilation on development of pulmonary fibrosis. So this was a hydrochloric acid-induced lung injury. Hydrochloric acid was given. 24 hours later, the animals were either ventilated or not ventilated for a couple of hours with a high tidal volume strategy or a low tidal volume strategy. And then after 2 hours, they were removed from the ventilator, breathed spontaneously, and they were followed then for 3, 8, and 15 days. And then measurements were made of a number of endpoints, including mechanics, pathology, and these EMT markers that I mentioned before. Here are the results in terms of the lung fibrosis score, and you can see the control, 3 days, 8 days, and 15 days, and these are the three groups: hydrochloric acid, spontaneously breathing, mechanically ventilated, and mechanical ventilation plus hydrochloric acid. And you can see that over the 2-week period that there was a marked increase in the lung fibrosis score on the pathology. When we looked at epithelial mesenchymal transition, basically, you can identify this by markers on the cells. You can see that cytokeratin, which is an epithelial marker, over 15 days, if you look at the red, decreased over these 15 days. And alpha SMA increased, this is a mesenchymal marker, increased. So basically, evidence that EMT was actually occurring. So in a summary article, we can think about this is an uninjured lung. This is lung that's injured because of mechanical stretch. Lots of things are released, as I showed you. There are cells that are recruited to the lung. And that can lead potentially to fibrosis by a number of mechanisms, including increased fibrocytes to the lung. In that study I just showed you, there were no increased fibrocytes. That's unlikely to be the mechanism. Fibroblast proliferation could occur, but certainly there was evidence for EMT. So why is this important in our patients with ARDS? Well, it's important because there are some data in the literature, not very much, that looking at mortality in patients who've had pulmonary fibrosis. So this was a study many years ago, relatively small study, in which patients who had lung biopsied were followed. Patients who had no fibrosis had a 0% mortality. Those with pulmonary fibrosis had a 57%. Now, the numbers were really small, so I would not extrapolate this to our general population of ARDS patients, but still intriguing. And a more recent study, and perhaps a better way, if you like, to study patients over a long period of time, is with high-resolution CT. And in this study by Ikata and all, they looked at high CT resolution on day one, and then they suggested that patients who had scores on their CT scan suggesting fibrosis had a mortality of 58%, and those who had HRT scores less than 210, mortality was 20%. So also suggesting that maybe fibrosis is important, maybe it starts to occur early. This was very early on day one. And that this could be an important phenomenon that we should be thinking about, not just in terms of the mechanisms and the factors we think about in terms of ventilator-induced lung injury now. The other important point about ventilator-induced lung injury, because of the biotrauma, are the systemic effects. And that can occur by a number of mechanisms, including release of various mediators, whether it be LPS, bacteria, various cytokines. This can, by various mechanisms, lead to multi-organ dysfunction and to death. And this has been something that we hypothesized a while ago, and there's evidence in support of this, but this hasn't been nailed down. We don't know whether this, in fact, is true or not, or just a correlation. Nonetheless, the organs that have been studied in the past have largely been the kidney, the liver, but there's also data now over the last couple of years suggesting that happens with mechanical ventilation may also affect the brain. And this was a study, this was a rat study in which these investigators used injurious ventilatory strategies and then looked at brain for various, stained the brain for various mediators. And this particular one, it was C-FOS. And as you can see, spontaneous breathing, C-FOS cells, low tidal volume versus high tidal volume, increase in C-FOS positive cells. And this was found in a number of regions in the brain. Another study published a couple of years ago as well, within the last couple of years, this was published in the Blue Journal, looked at both mice with or without vagotomy, and they ventilated those mice, again, with an injurious ventilatory strategy, looked at hippocampal slices, and then looked at humans and measured the spindin-1 from the brain samples of these patients. And what they found was, if you look at days of ventilation, immunohistology score, ventilated versus non-ventilated, there was a tendency towards the ventilated patients having higher immunohistochemical score, histological scores. Of course, in humans, it's really hard to sort out the mechanism, what's cause and effect here. So I don't think we can say anything specifically about cause and effect. The animal studies were more convincing, but the important point was it looked like there may be an effect of what we do in terms of ventilation on the brain. Why is this important, potentially, in patients with ARDS? Well, there's, as you all know, the follow-up, if you'll follow up patients for a period of time after they've been in the ICU and ventilated, there's not just effects on pulmonary function, not just effects on cardiac function, but there's also effects on cognitive outcomes. And this is one of the earlier studies from Hopkins and colleagues in which they looked at 1 and 2 year cognitive outcomes. And you can see on discharge, these are this y-axis here is patients with deficits. 70% of patients had deficits in terms of processing speed, which got improved. Same with memory, executive function, attention, and even IQ. So there can be impact on the brain. And this suggests that, well, maybe it's not just everything else that's going in the ICU, but maybe the way we ventilate them may actually have an impact as well. So finally, the last issue I'd like to address is how do we assess the likelihood of ventilator-induced lung injury at the bedside? Seems sort of obvious, and yet it's not so trivial to do. We often think about volume trauma, so we think about tidal volume. Tidal volume is important, and we know the ARDSNet study, in 2000 showed a big decrease in mortality. We think about keeping the plateau pressure less than 30. Plateau pressure, as you know, is affected by other chest wall mechanics, so it may not be a great surrogate for are we causing overdistension. The stress index is something that was introduced a few years ago to actually try to assess whether there's recruitment of lung and derecruitment and whether there's overdistension. Data on electrical impedance tomography, CT scans, largely in research settings, and the use of transpulmonary pressure. So all of these things have been suggested, and all of them have some utility, but they're not perfect. And what I'm going to show you next is not perfect either, but it's another way of looking at this question. So this is a paper published a couple of months ago in the New England Journal of Medicine, looking at driving pressure and survival in patients with ARDS. So first of all, what is driving pressure? There's actually a couple of definitions of driving pressure, a few definitions. The one that's in the literature, one of them is peak inspiratory pressure minus plateau pressure. That's driving pressure. That includes the flow resistance, of course. The one we're using in this paper is plateau pressure minus PEEP. And I've shown sort of two PEEP levels here. If there's auto PEEP, that can have an impact on what this driving pressure is. But let's ignore that for the moment, although that might be an issue. So delta P as a potential mediator of lung injury in patients with ARDS. So we're going to focus on delta P. So what is it? If you think about the definition of compliance, so respiratory system compliance is tidal volume divided by plateau pressure minus PEEP. Remember, plateau pressure minus PEEP is the driving pressure. So delta P, just doing a little bit of algebra, is tidal volume divided by the respiratory system compliance. Why did I put it in this way? Well, I put it in this way because, in essence, delta P is the tidal volume normalized for the compliance. And if you think about how you want to ventilate patients, if they have baby lung, they have a small bit of lung, you want to ventilate them, give the tidal volume based on the size of the lung. So this is a way of getting at that. Now, this is respiratory system compliance, and we can talk about that afterwards, whether that's an issue or not. But delta P is equal to both the decrease from plateau pressure to PEEP, but as I said, can be thought about as the tidal volume normalized to respiratory system compliance. The ARDSNet investigators, when they published their paper, normalized tidal volume to predicted body weight. And the reason for that is that lung size varies as predicted body weight. And the idea was, rather than using measured body weight, which was used, quite frankly, for the previous 30 years, prior to that, it was, let's get it to the lung size. Well, patients with ARDS, they don't have normal sized lungs. They have lungs that are smaller, and this is a way to get at that. So the hypothesis of this paper was that if you scale VT to this compliance, would be a better predictor of lung protection than just using tidal volume scaled to predicted body weight. And the methods were a standard risk analysis. That's basically multi-level regression analysis with appropriate corrections, and something called mediational analysis, which quite frankly I'm not an expert on, and I'm not going to present those data here, but it's a way of determining if you change a factor in an independent variable and you get an effect, is there a direct relationship or does it act via some other mediator? And the statistical approaches to do that tell you if it acts to another mediator, it might give you a better handle on what the mechanisms are, and actually maybe give you a better handle on how to control things in the first place. And you'll see what I mean, I think, as we talk about this. The derivation sample for this standard risk analysis was a few hundred patients based on 4 studies. and then validated with 3,000 patients. So we had patient-level data on all the major studies that had been published on randomized controlled trials on lung protection in ARDS. I don't expect you, this is a complicated, busy slide, not complicated. I don't expect you to read all of this, but just to show you these are the studies we used, and these are just the Kaplan-Meier curves to give you a feel, and I'm sure many of you know many of these studies. So what were the findings? Well, you saw this finding already. This is now on the x-axis. There's the cohorts of different patients divided into 5. Those with the highest plateau pressure on the right, those with the lowest plateau pressure. This is airway pressure on the y-axis, and here on the y-axis is the relative risk of death. And as you can see, as plateau pressure increases, while PEEP is maintained constant, there's an increase in mortality. Not surprising at all, as we know, increased plateau pressure, that's what we'd expect. Look at the next slide, though. This is interesting. This is now the increase in plateau pressure, which is roughly the same as the increase here. But now PEEP is increasing, so delta P is remaining constant. And as you can see, when that happens, no change in mortality at all. And what happens if we now keep plateau pressure constant while delta P decreases as PEEP increases? And as you can see, there's a decrease in mortality. So these data suggest delta P looks like it's a pretty good marker of mortality in patients with ARDS. This is now the relative risk versus delta P, and you can see again a dose response curve, which is quite interesting, especially when you think about the median tidal volume. This group here had a median tidal volume of 6. This group here had a median tidal volume of 6.1, essentially the same. And this group had a median tidal volume of 8. But some of these patients had tidal volumes of 5.7 all the way up to 12.1. That's actually an interquartile range. So just showing a dose response curve, showing that as you increase delta P, that there's an increase in mortality. Now, I think a natural question, if you're sitting in the audience, is normalizing to predicted body weight just as good? We know that tidal volume to predicted body weight, that's what we usually use at the bedside. Can this give the same sort of results? Well, it turns out that it doesn't, and I don't have time to show you all the data, but I summarized, took it from the supplement and summarized. Here's what happens when you look at normalized predicted body weight. Tidal volume divided by predicted body weight while maintaining plateau pressure constant. That's the key, because quite often if you have different patients, in the same patient as you decrease tidal volume, plateau pressure would decrease. This is assuming it remains constant. You can see the relative risk doesn't change at all. And of course, I showed you this essentially. When you normalize to compliance, there's a decrease, and the relative risk is decreased. So, and there's other data to show that tidal volume normalized to body weight doesn't do it, both in terms of data like this, but also in the mediational analysis that show that that's not the critical variable, that it goes through delta P. So why are these findings potentially important in patients with ARDS? Well, I think in terms of randomized controlled trials, pretty obvious. You'd like to stratify patients, ideally have patients in both groups that are equal likelihood of death. This would help with that. For some studies, it might identify patients at high risk of death related to the ventilation strategy potentially. For example, if we're going to do a study on ECMO, wouldn't it be nice to pick the really high risk patients as opposed to all patients? This looks like delta P is better than looking at plateau pressure to do this. In terms of the clinical utility, for prognostication for patients in the ICU, and perhaps it might be helpful to choose the optimal ventilatory strategy. In other words, we might say, let's take patients and now measure delta P as you make any changes and try to minimize that. Our study didn't show that, by the way. Our study basically was an epidemiologic study. Didn't say if you took patients and you actually changed the ventilatory strategy based on delta P, you could improve outcomes. So I want to make sure that's clear. There is one area where I think, though, that we might start to think about using this at the bedside to actually manage patients. And that's in patients who have plateau pressure greater than 30. As we know, these are difficult patients because we don't know often, and you saw this slide, we don't know often whether, in fact, when the plateau pressure is high, whether there's increased stretch, as shown here, and even though this, forget that this is low, but is there increased stretch? Or the plateau pressure going to be high, but because there's a stiff chest wall, that in fact there's no increased risk of ventilator-induced lung injury. And we know this. If you take a patient who has a massive ascites, you look at their chest X-ray, they can have a plateau pressure of 35. Their lungs are tiny. Their lungs are not being overstretched. They're not at increased risk of ventilator-induced lung injury. How do you assess that at the bedside? So in summary then, I think ventilator-induced lung injury is an important entity. I think we'd all agree to that. Ventilator-induced lung injury can impact not just to the lung in terms of biotrauma or barotrauma, but might also lead to pulmonary fibrosis. And perhaps, very importantly, might have an impact beyond the lungs and affect the brain. Driving pressure is a key variable that appears to mediate the beneficial effects of lung protection. So for clinical trials, I think the delta P would be useful to identify patients at high risk of death. And at the bedside, I think it's a fairly good predictor of mortality. If you're looking at the ventilatory, of course, there's other predictors of mortality, including age and degree of hypoxemia. Whether it's useful to set the ventilator settings at the bedside, I'm not sure yet. I think we do need a randomized controlled trial to look at that. But I think for patients with plateau pressure greater than 30, where we know the current ARDSNet approach really is wrong in a sense, physiologically, because if patients have stiff chest walls, I think it might be something that we could use now at the bedside and taking care of our patients. Thank you very much, and I'd be happy to take questions.